This video demonstrates the technique of coloplasty for congenital short colon in a 11-month-old boy. A window colostomy of the pouch had been done at birth, and over the past 11 months this resulted in a complete everted prolapse of the pouch. However, as you can see from the health and general condition of the baby, this did not affect the growth and development. In the picture, one can see a large everted prolapse of the pouch with the opening placed inferiorly just above the inguinal crease. Preparation is done from the subcostal margin to the mid-thigh region.
Basically, you're getting a surgeon's eye view of the proceedings, which is what it should look like. Because if you orientate it according to the long axis of the child, so towel clip. Dilocan Edlin दे दीजिए.
दूसरा बच्चा जैसे बोले थे
वाइट टॉवल से वाइट बैलेंस तो नहीं करवा रहा है.
ग्रीन होता है तो सर वो ज़्यादा ग्रीन होता तो ज़्यादा
ग्रीन ज़्यादा बेटर लगता है. ग्रीन टॉवल है क्या कोई?
शीट होगी ब्लू शीट
तो फर्क नहीं, ऐसे ज़्यादा तो क्लियर नहीं है.
कंट्रास्ट आ जाता है. अच्छा
ठीक है.
The drapes are applied, excluding the operative field, and 1:400,000 lignocaine with adrenaline is then infiltrated into the skin at the level of the highest inguinal crease, which will form the line of our incision. This infiltration is also carried out around the rim of the window colostomy, as can be seen here.
Dilocan Edlin और चाहिए होगा. कितना लिया था? 2.5 का 5.
The incision is made starting just to the right of the midline at the level of the highest inguinal crease, and at its left end it curves upward to incorporate the margin of the window colostomy, so that the window colostomy can be mobilized as a part of the incision. The deeper layers are divided with diathermy, and hemostasis is ensured with coagulation.
लीडर
That piece but this curvilinear issue will not be.
ऑस्ट्री.
Now, as you can see, the length of the incision outside the rim of the window colostomy is quite short, but once the colostomy is circumscribed by the incision, the actual access becomes sufficient for performing the whole operation. Therefore, one should be careful not to make too large an incision outside the window colostomy, keeping in mind that the circumference of the window colostomy incision is also going to provide access later on. The subcutaneous tissue and the anterior rectus sheath are divided in the line of the incision, and the left rectus abdominis muscle is transected to get access to the underlying peritoneum.
कृष्णा
ये नहीं खुली। हाँ खुल गई, चलो। ये मिड लाइन है क्या? ये क्या आ रहा है बीच में?
मिडलाइन से लैटरल
मिड लाइन से लेफ्ट में तो कुछ आ रहा है। ब्लैडर।
In the smaller children, it should be remembered that the dome of the bladder arises well out of the pelvis, even when empty, and therefore, while incising the infraumbilical peritoneum, care should be taken to see that the bladder is not incised. It is helpful to identify the median and medial umbilical ligaments, which are the fibrosed umbilical arteries, to get a guide to the apex of the bladder, which can be preserved. You can see here that the apex of the bladder is appearing near the ventral lip of the incision, and care should be taken not to cut into it.
छोटे लैंडिंग बैग पे
ये एक और कॉर्ड आया, मीडियन एंड मीडियल अम्बिलिकल लिगामेंट्स है ना।
Once the peritoneum is opened safely with a finger inside the peritoneal cavity, the rest of the incision is completed.
अच्छा होल्ड। कर देखते हैं अभी। ओके लेट्स गो फर्दर। अभी मसल डिवाइड हो जाएगा। Now let us stop whatever is bleeding here. Okay. Catch.
That is the peritoneum which was incised on the right lateral side of the dome of the bladder, which is then released from its tethering to the anterior abdominal wall, and this enables it to drop down into the pelvis. Particular care has to be taken, as I've mentioned before, to protect the dome of the bladder from injury while opening the peritoneum.
सीधे ही इसी से काटते हैं आप?
काटे से
काट सकता है ऐसा कुछ?
Once the right hand side of the incision is completed, we continue it around the circumference of the window colostomy to mobilize the colonic pouch from the abdominal wall, thus enabling us to perform the coloplasty.
Now let's hold.
The skin and the deeper tissues are incised with cutting diathermy just outside the mucocutaneous junction of the window colostomy, and this enables the pouch to be mobilized completely from the anterior abdominal wall.
राइट साइडेड अनडिसेंडेड टेस्टिस किया
है
लेफ्ट साइडेड तो हर्निया है
हाँ, right sided।
यूडिटी में
कॉग्निशन।
बट पैल्पेबल तो है ही। देख लीजिए पैल्पेबल थोड़ा रिलैक्स।
भैया डाउट हो तो रुक जाओ, ये थोड़ा वीआईपी है बच्चा। कॉग्निशन लाइट कम है।
So here we can see the last part of the attachments of the pouch colon to the anterior abdominal wall being divided, and this results in the pouch being free from the site of the window colostomy. Due to the large eversion, a large amount of small bowel is contained inside the everted pouch, and the first step is to reduce this small bowel and the greater omentum from inside the everted pouch, and this can be seen here. The small bowel is pulled out right up to the extent where the terminal ileum joins the pouch. You can see part of the cecum coming out there. Now, due to the large eversion, the opening of the pouch is a little small to reduce the contents completely. Therefore, it is incised at one point of its circumference to enlarge the opening and thus permit the pouch to be inverted to its normal shape.
थोड़ी अच्छी होनी चाहिए वो।
ये इस तरफ डार्क है जो हमारी साइड है,
ये सर यहाँ कर दीजिए लाइट, ये वाली।
यहाँ करो। हाँ
Yeah,
ओके
better,
बेटर,
comparatively,
मच बेटर, बस दैट्स इट। अच्छा दूसरे कैमरा शिफ्ट हो रहा है यार, देखो बच्चा नीचे खिसक गया रिलेटिव।
क्या लाए
ये पकड़ लो दोनों।
So that's the opening of the window colostomy being enlarged to allow the pouch to be inverted back to its normal shape.
ठीक है, now you can just for a second show the,
And this allows one to appreciate the anatomy of the pouch. That is the front surface and that is the back surface. You can see the small bowel coming in from the left side to the right. That is the junction of the small intestine with the pouch. Which also parallels the course of the superior mesenteric artery to the mesenteric border of the intestine and the mesenteric border of the short colon. A few adhesions remain which tether the pouch to the lateral abdominal wall, and these will now be divided to enable us to see the colovesical fistula.
No problem, sir. मोमेंटम टेस्ट अच्छा वो मत छेड़ो तो यहाँ से सप्लाई होती है इसमें
मेजेंट्रिक
अब बावल बाहर निकालो तो वी कैन शो द फिस्टुला
एक 8 नंबर का फुलीज है
एक बता दो बैक टॉप है तो ठीक
So the dome has been grasped here of the bladder, and we can clearly see the junction of the short colon with the posterior wall of the bladder, which constitutes the colovesical fistula. And from the outside it is clear that this fistula is quite wide. However, later on in the operation we will see how narrow the actual internal opening of the fistula becomes. In order to isolate the fistula, one has to get behind the short colon, and for this reason the peritoneum on the posterior surface of the bladder is divided, taking care to stay away from the vas deferens which come in on either side very close to the colovesical fistula.
सिंड्रोमिक लुक है सर बच्चे का
Here we are dissecting the peritoneum on the posterior surface of the bladder and lateral to the colovesical fistula on the right side of the patient, and very soon the two vas deferens will be clearly visualized as they course medially from the internal inguinal ring. We can now see the superior limit of the fistula, and an attempt is made to divide it by bipolar diathermy. However, unfortunately the instrument was not working properly. Therefore, we had to go back to standard scissors dissection and monopolar diathermy.
ये आ गया फिस्टुला
नाम किसने भेजे थे निकाल दिया किसी ने लड़के
You will notice here that I have the urinary bladder grasped in the thumb and forefinger of my left hand, and occasionally before starting to cut with the bipolar diathermy, I feel for the boundary between the urinary bladder and the fistula arising from the colonic pouch. This is important so that we do not include bladder mucosa in the colonic pouch and divide the fistula precisely at the junction of the pouch and the urinary bladder.
वायरस के कारण
टाउन्स हैवी इसके
नहीं सर लग तो नहीं रहा हमको तो नहीं
बेसिक तो
लगा
है सर इफ यू गेट द डिस्टेंस थोड़ा सा
अरे वो नॉर्मल
मतलब मेंटल ग्रोथ वाइज इज
Normal
नॉर्मल सब कुछ बता रहे हैं
बहुत सारी
Look
चीजें
wise.
फ्रंटल लॉजिंग
उसकी मदर का देखिए आप, उसकी मदर का भी ऐसे ही। The opening is usually beyond the ureter. I mean, just below.
हाँ हाँ क्लोजली फ्यूज्ड है ये हाँ ब्लैडर मसल छुड़ा के चल रहा है
हट गया आ रहा था बिल्कुल क्या सर उसके कंसेंट लेवाएं क्या
हैं
कंसेंट
इनसे कहिए बिल्कुल एक्टिव है, कुछ भी नहीं है। नाम आपको बताते हैं।
सेमी वीआईपी है
Apart from the fistula, there are peritoneal bands anchoring the colonic pouch to the retroperitoneum, and these also need to be divided so that the pouch is completely freed up for performing the coloplasty.
investigations which will help us ये पता नहीं देखो ये वहाँ से ये वहाँ से हाँ so let's stay away from those scissors
Coming up near the fistula on the right hand side of the patient, we are dissecting to keep the vas separate from the colonic pouch. While mobilizing the vas, it is important to keep a peritoneal covering adherent to it, as it is not advisable to skeletonize the vas deferens.
It's 9 hours.
always close to the fistula so I think we should take this off ये पकड़ लो ऐसे ये पकड़ लो scissor
You can here see the vas deferens coming into view on the ventral side of the peritoneal fold just near the tip of the scissors. At its terminal end, the seminal vesicles are extremely close to the junction of the fistula with the urinary bladder and have to be carefully preserved to prevent damage.
and that's the one on your side we will come to that okay good now you see two leaves you will go between them अपनी ठीक
अरे संजय उसकी ड्रिप ऑफ कर दे उसकी ये लो ये खड़ा कर थोड़ा
बस 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 You see the mask? They can see it now.
खड़ा कर दो उसको चला के
Right?
Yeah,
That's the
clear.
vast there. Okay. And the other one? The other one is here. बस ये देखिए.
Light थोड़ी सी ये वाली focus करो.
So that's the vas deferens of the left side, coursing very close to the colovesical fistula at its terminal end, and this is the vas deferens just near the diathermy tip of the right side.
Back करो.
थाई मास लेना है फिर क्या?
थाई मास तो मुझे करना है. वो भी वेट करना पड़ेगा. नहीं आई.
अब आए.
Here we are separating the last few peritoneal adhesions on the posterior surface of the fistula, very near its termination into the bladder. And once the fistula is completely isolated, it can be transected close to its junction with the urinary bladder.
दिख रहा है उसमें कुछ?
हाँ सर. हाँ थोड़ा zoom out करो.
नहीं जूम आउट रेजोल्यूशन खराब हो गया जैसा पहले आप थोड़ा ही तेज करना
चलो. ओके. उधर वास डिफरेंस भी ठीक है, इधर का भी ठीक है. ये फिस्टुला. सपोर्ट पेज उसकी. ठीक है. लेट अस सी.
So the fistula has been divided completely, and a small vessel which is bleeding near it has been coagulated. You can see that the opening of the fistula on the bladder side is actually very narrow, despite the wide appearance of the fistula on the outside. Once the division of the fistula is complete, a few remaining adhesions are divided at the point where the ileum joins the pouch. It is important to have the pouch completely free of all kind of peritoneal bands so that its anatomy can be appreciated fully and the longest possible length of tube can be constructed using coloplasty.
ठीक है. अब आई आइडिया.
दिख रही है. Now it is clear. This is the ileum. थोड़ा सा colon.
ठीक है. दोनों यूरेटर.
Just to demonstrate how narrow the vesical end of the fistula is, you can see that urinary stream which came through the opening. It is actually really tiny, and this is because the window colostomy forms a very good alternative pressure release valve. So there you can see the small opening of the fistula through which we can enter the bladder, and the catheter has now been pulled into the bladder from the outside. The urethra could not be catheterized preoperatively because the child had a common cloaca. So a Foley's catheter has been pulled into the bladder and its bulb will be inflated before the opening in the bladder is closed.
Okay, okay. Wait. चलो बैलून फुलाओ वाइकल दे दो एक मिनट
पीछे ले
डालो
तो फूलेगा ना, उसके बाद आप खींच लीजिएगा, अंदर चला जाएगा।
खुल गया बस दैट शोज अस द फिस्टुला बेटर चलिए सॉरी ये मेरी लैपटॉप
हो गया ना। ऐसी एक स्पॉटलाइट इस तरफ से भी होनी चाहिए थी।
So the Foley balloon has been inflated and the fistula will now be closed over using a couple of stitches of 4x0 polygalactin or Vicryl.
कट प्लीज
सर एक्सक्यूज मी, ये सर हम फ्यूचर बदलना चाहते थे तो वहाँ भेजा बाहर रजिया को, तो शी डिनाइड।
क्या हो गया
तो इन्होंने बोला डॉक्टर राशिद तो मांग रहे हैं तो ये बदलना चाहते हैं। नाउ हमने अब कहा जब बता देना कुरियल साहब को करना है, अब बदल दिए, पहले डिनाई करिए जब बता देना इसी से
क्या
करना
है वाइकल
नहीं, सर,
बदलना है?
नहीं साइकिल के बदले हम लेना चाहते थे
अच्छा
तो बोले नहीं उनको बता दे इसी से कर ले।
पेपर कट नीडल
अब हमने बताया कुरियल
अच्छा।
साहब को करना है, अब बदल दिए।
ठीक ओके
टाइटल की टेपर कट होती है ना फिर नीडल तो
हाँ
एनास्टोमोसिस
ऐसे भैया
नहीं, वो
हम
कल
तो
बता रहा था, टेप-
सारे में जितनी एनास्मोसिस कर रहा हूँ सब कटिंग से कर रहा हूँ,
अच्छा,
सब टोटल जीरो।
थोड़ी सी नॉटिंग की प्रॉब्लम है सर।
इसमें हाँ नोट ज़्यादा लगाने पड़ते हैं, दैट आई अनडिनाइबली एग्री। चलो लाओ, है ना? ओके सो व्हाट आई प्रपोज टू डू इज नाउ दिस इज व्हाट आई वांट टू शो। एक मिनट सर,
We can now appreciate the anatomy of the pouch more fully. This is the superior mesenteric pedicle coming in on the mesenteric border, and one can clearly see the bifurcation and the pulsations of the artery. Turning the pouch over, we can also clearly see the much denied inferior mesenteric pedicle which courses towards the fistula. Clearly demonstrated here. A small inferior mesenteric pedicle which courses towards the fistula. Now, to get a complete tube, it is necessary to divide right along the circumference from the ileo-pouch junction up to the fistula, preserving the fistula. Making a simple V cut will not accomplish the purpose of producing a long, thin tube, and this is the most common reason for the frequently encountered problem of tube dilatation after surgery. The pouch is a very vascular structure, so it is helpful to occlude the superior mesenteric pedicle with the bulldog clamp before cutting into the ileal pouch junction. Construction of the tube begins by cutting at the point where the ileum joins the pouch staying close to the mesenteric border and cutting out a strip of tissue which is 1.5 to 2 centimeters wide. Certainly it should not be any wider than that, otherwise the constructed tube will be too large in diameter. Depending on the experience of the surgeon, one or both walls can be cut together, but it is important to ensure that the strip of tissue does not exceed 2 centimeters in width. This is the single most important technical step on which the future success of this procedure depends, and you will see this being carefully followed during the course of coloplasty as shown in the next 25 to 30 minutes. Please notice that the cut is being made parallel to the mesenteric border and that the strip of tissue that remains to be sutured into the coloplasty tube is just about 2 centimeters wide.
थोड़ा सा फील से बाहर आ रहा है, अब ठीक है।
कैच बस इधर रखना एंड जस्ट इंश्योर इट रिमेन्स इन द फील्ड।
Continuous?
नहीं नहीं, इंटरप्टेड। ओके,
Suturing of the coloplasty tube is again done using 4,0-polygalactin. I used to prefer interrupted sutures closing only the seromuscular layer. However, lately we have started using linear stapling device for the same, which has been demonstrated in another video.
उसको थोड़ा रखो, फील्ड में देख लेना, बस फील्ड में रहेगा। दिख रहा?
हाँ हाँ सर।
लाइट डार्क तो नहीं, और आप सीजर वही ले लो।
Keep it here.
हाँ, you keep it wherever you think best, so that we can.
सर
सिंगल लेयर में ही होगा सर।
सिंगल लेयर।
Needless to say, it is important to carefully adjust the gap between the interrupted sutures to provide a watertight closure, and also that as it is a very long suture line, it is quite helpful to keep telling jokes to your assistant so that they keep awake and help you properly.
वो बुलडॉग पे टाइम पे ध्यान रखना, नॉट मोर देन 20 मिनट्स एट अ टाइम, तो रिपरफ्यूजन इंजरी होने लगती है। अगला वाइक्रल सूचर तैयार रख लीजिएगा। एक हमको डायलेटर थोड़ा पानी डालना। बस नहीं पतला चाहिए।
You will notice that an extramucosal technique of suturing is being used here, which is picking up only the seromuscular layer of the short colon. Since there will be a proximal ileostomy to cover the suture line, this is sufficient to provide an adequate construction of the coloplasty tube. During the initial years, we used to do a two-layer closure with the first layer of absorbable suture and a second layer of silk. However, with the advent of better suture material, the two-layer technique has been replaced by the single-layer intrapid extramucosal suturing, which we have found to be quite adequate, and there has been no instance of leakage using this technique in our patients.
एक 10 मिनट बाद भैया यूरिन चेक कर लेना, फ्लूइड रेट बढ़ा दो यार।
अभी तो कुछ आया
नहीं अभी तो सब खाली हो गया। ओके सर।
So, having reached the end of that segment which we had cut previously, it is time to extend the cutting of the coloplasty further. And again, you will notice that the same principle is being kept in mind, that the strip of tissue remaining at the mesenteric border should not exceed 2 centimeters in width. You will also notice that the mesentery of the short colon, which is lying just posterior to the muscular layer, is not being divided, and this helps to preserve the vascularity of the colonic tube right up to the very end. There is a percentage of cases in which the inferior mesenteric artery is absent. Even then, the superior mesenteric supply extends along the mesenteric border right up to the level of the fistula and will allow construction of an adequately long coloplasty tube. At the moment, we can see that the surface of the mucosa is quite pale, but if the bulldog clamp is released, it will pink up within seconds. And that shows you that the vascularity is actually maintained right along the length of the proposed coloplasty tube.
We are not cutting an avascular organ here, so we reclamp and we continue to suture. And we wash hands in the middle also. ठीक है जी, लगे स्टिच। करो वो अभी तो चल रहा है। चलो चलो ठीक है, ओके नो प्रॉब्लम। हाँ फील्ड देखना भैया, फील्ड में रहना चाहिए बस. And at the end of it, from that tiny little ball, we are going to get about a foot of colon, which is what the kid needs.
इसमें डायलेटर डालेंगे?
हाँ डायलेटर में डाल के दिखाना चाहता हूँ कि ल्यूमेन इज स्टिल पेटेंट बट इट इज़ थिन. ये लोग जब बकवास करते हैं ना चड्ढा वड्ढा,
हाँ सर.
lot of bakwas is being done. So you can actually negotiate the dilator right up to the tip. And udhar na kicho. And if you want, even into the ileum. है ना? Still leaving a big enough tube here. बस ये है कि वाला टाँके लगाते लगाते आदमी दिख रहा हो या लाइट कुछ कम हो गई मेरी?
नहीं सर ठीक है. अलग कर लेंगे.
कट सब only joining the muscle which is quite thick.
That has to be done.
हैं?
हाँ सर. वैसे इन्वर्ट भी.
हाँ म्यूकोसा इन्वर्ट हो जाती है. ये साफिल है वाइक्रिल है?
ये वाइक्रिल है.
अच्छा नहीं साफिल दे दी, सही चल रहा था हमारा.
सैफल से कोई प्रॉब्लम नहीं. थोड़ा यूज टू होने में टाइम लगेगा.
हाँ आई एम इन द हैबिट ऑफ नोटिंग इट 5 times. मोर इस सेक्शन में आते आते देखो द थिंग्स बिकम क्वाइट सिंपल. हाँ 4-0. नेक्स्ट वाले में आर्टरी बढ़ा देंगे. Retroperitoneal mass with obstruction.
हाँ सर.
मैंने जब लास्ट टाइम सुना था तो उसके बाद मैं ABC करने वाला था. मैं फूल ऑफिसर था तो प्रोफेसर KD वर्मा की इमरजेंसी मैंने एक दफ़े उन्होंने कहा कि आप तो बाहर जा रहे थे तो इमरजेंसी देख लेना. फ्राइडे उनकी इमरजेंसी होती थी.
So we continue with the construction of the coloplasty tube, taking interrupted extramucosal sutures. It is also useful to frequently irrigate the tissues with normal saline to prevent desiccation as we work in an air-conditioned theatre.
घोलना पड़ा. मैंने कहा यार देखा तो नहीं आज तक जब तक कि सर उसमें शायद IVC खुल गई है. एडियरेंट ट्यूमर था, IVC खुल गई. हमने कहा अच्छा ऐसा इमरजेंसी में उन दिनों डायथर्मी तक नहीं होती थी. तो इट वॉज सर्जरी इन ट्रूली हार्ट वार्मिंगली प्रिमिटिव सर्कमस्टेंसेस.
It will be noticed that tuberization of a 1.5 to 2 centimeter wide strip of the colonic pouch results in a tube which is about 1 centimeter in diameter. and a little while ago we put in a dilator into the lumen to show that it is continuous, and we will again calibrate the lumen with a dilator once the end of the suture line is reached. As the tube suture line crosses the point of maximum convexity of the colon, a slight twist occurs in the suture line, which then comes to lie on the right side of the patient instead of exactly on the antemesenteric border, and you can see here that suture line is now moving towards the right hand side. This does not affect the operation as such, as the taking of interrupted extramucosal sutures will accurately coap the two edges.
ब्लड नहीं था, कुछ नहीं, वो
4-5 केसेस अब हैं जो उनमें आईवीसी बांधा गया,
बांधा गया,
तो वो सर्वाइव कर गए.
करेक्ट. सो
That shows again the power of Almighty.
पावर ऑफ ऑलमाइटी, आई टेल यू. एक आया था आइसक्रीम के ठेले वाला. He had somebody had pushed his thela against him, so the handle had gone into his left hypochondrium, and he ruptured his spleen. And he was a destitute boy, about 22 years old. एमएनसी में आया वो. तो ब्लड कहाँ से आए? So we were about to explore. We made a mini laparotomy, and there was sterile blood inside. So we just collected it in glass bottles and retransfused it. Retransfused it with a filter. About 1.5 liters of blood. दिख रहा भैया? फील्ड में है मामला.
Exactly.
Okay, where are we now?
There are great chances that these, coloplasties leak.
नहीं, they don't. Why? Because we'll be doing an ileostomy.
आइलेस्टमी कवरेज देंगे ना.
Nee,
We'll be
I
doing
know.
an ileostomy.
But that
नहीं करता.
minor leak, in fact, even that will make a dense adhesion around that.
नहीं करता.
होता नहीं है इधर तो.
कोलोप्लास्टी में लीक बड़ा होता मैंने. I mean, this one might leak. वो बात अलग है. Just because I've said it's uncommon.
This clarity is good.
The problem is of vascularity of the distal end. ये बाहर निकल गया होगा, देखो. आउट ऑफ फील्ड हो गया. Right, sir. Let us put a dilator again. Let us release this for a second.
So by releasing the bulldog clamp again, as near about 25 minutes have elapsed, we see that the mucosa of the inside of the colonic pouch pinks up again right down to the very end of the colonic tube, showing that the vascularity is maintained throughout the whole length of the coloplasty tube. Small bit of oozing can also be seen from the open edges. Therefore, there is no danger of the tube undergoing ischemic necrosis in any part. Which simply goes to show that the coaxial blood supply in the wall of the short colon is so good that even with the mesentery not running all the way down to the fistula, the vascularity can be used to construct a fairly long length of colon without danger of ischemia. So here we are cutting the remaining part of the tube from the colonic pouch and the slight depression at the distalmost end is the inside view of the fistula, which is being pointed out here. And we nowadays preserve this using the actual opening of the fistula as the anal opening. Therefore, the cut in the terminal part of the tube will actually go around the fistula rather than through it. There you can see the fistula being demonstrated from outside inwards, and we will cut the tube in such a manner that it curves around the fistula, thus keeping it as a part of the coloplasty tube itself. Just reapplying the bulldog clamp to prevent excessive oozing. This demonstrates the continuity of the whole lumen of the coloplasty tube, and you can see that we are actually using a 8 French size Hagar dilator which fits snugly inside the colon. And it cannot be reiterated often enough that it is important to keep the diameter of the colon as narrow as practically possible to allow adequate propulsive function and prevention of postoperative dilatation.
Okay, we can still see it. Let's see. लंबा कट लॉन्ग ऐसा फिर छोड़ दो उसको चाहिए ठीक है, are we still in field? scissors क्या हो गया? Looks all right, and it's covered by sort of mesentery on all sides. हैं जी, क्या है? लिम्फोमा तो नहीं है? निकाल रहे हो?
सर आप देख लीजिए, रिसेक्ट कर लीजिए बायोप्सी। वैसे तो ऑब्स्ट्रक्शन में
कर सकते। फ्लूइड बढ़ाया, तो हार्ट रेट बढ़ गया इस बच्चे का। लगा रहे हो?
ब्लड लगा दिया।
अच्छा ओके, चलो ठीक है। Nearly at the end.
There is a particular reason for showing the complete construction of this coloplasty tube from the ileo pouch junction up to the terminal end of the fistula without editing out any of the sutures placed, because there are a lot of misconceptions about coloplasty, and I hope after seeing this video one will realize that properly done, this operation is capable of providing the child with a near normal, if not normal, colonic function.
इधर से लग जाए तो बेस्ट है ऐसे।
So now we can see that with single layer cerebromuscular interrupted sutures, we have come nearly to the end of the colonic tube. The dimpled area just distal to the point which is being sutured is the inner opening of the fistula, and in keeping with the thought that the fistula sometimes contains involuntary muscle fibers, I have started preserving the fistula and using it as the definitive anal opening. And how this is incorporated into the colonic tube will be shown in just a little while. Now here you see we are beginning to divide the last part of the colonic tube, incorporating the fistula in the ventral wall of the tube. So the cut goes completely round the margins of the fistula. There you can see the fistula from the outside, and it is preserved as a part of the colonic tube. So we have excised the part of the pouch colon which contains the colostomy, both the anterior wall in which you can see the colostomy opening and the posterior wall which forms its opposite number. This tissue is then discarded or subjected to histopathological examination, and there you can see the fistula being demonstrated from inside out. And the last part of the colonic tube is going to be closed now. The opening of the fistula just widened a little bit before we close the last part of the colonic tube to complete the coloplasty.
Because Dr. Kuril is very sentimental about this.
Yes, very sentimental. So we must respect his sentiments.
Exactly.
चाटू कैंची है।
not looking like a colon.
हैं?
Later on, diarrhea and all that.
बदलो स्विचर चाहे पुराने टुकड़े दे दिए चल इसको पकड़ो गेट एन आर्टरी टू इट पकड़ लो कोई टिश्यू पकड़ लो यहाँ पे ये वाला टिश्यू पकड़ लो एनी वन दैट यू थिंक
Idea is very novel. This coloplasty.
हाँ
Coloplasty.
इट्स नॉट अ न्यू आइडिया
People, I mean, that's the older one. But people still believe in resecting and all that.
यस वी डू दैट
Do
इज
ilionoplasty. I will put it. Means a normal peristalsis anyway,
Oh, it
any
does.
point
I'll
of
show you
life.
follow-up X-rays.
So that's, I mean, that will be a static X-ray. Dynamic X-ray showing peristalsis.
डायनामिक तो वो राशिद बताएगा तुम्हें जो उसने वो खोला शॉर्ट कोलन वाला फॉलो थ्रू एडिज ऑब्स्ट्रक्शन के लिए जिसमें कोलन पेरिस्टल से हमने अपना पेशेंट खोला है दोबारा आई ओपन माई ओन पेशेंट एंड द ट्यूब पेरिस्टल्सिस रीजन इज यू अलाउ इट्स वॉल्स टू कोएप्ट
But histologically, they have said there's a few ganglionic cells and lack of plexus.
ना 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 वो गलत है गैंग्लियन सेल्स है नॉर्मल और है
Sorry, sir. Maybe not.
यूरिन आया कम है यार भैया फ्लूइड बढ़ाओ साथ में फ्लूइड दे दो या ब्लड बढ़ाओ कुछ करो यूरिन कम है यूरिन कम है एक कंपेंसेटरी मैकेनिज्म में इस समय हार्ट रेट चल रही है नहीं तो वो फेल हो जाएगा तो मुश्किल हो जाएगी क्योंकि इनसेंसिबल लॉस की कोई सीमा नहीं है इसमें इस ऑपरेशन में आर्टरी छोटी एक व्हीकल वैसे ले ही लो क्योंकि अभी वो दो जगह और चाहिए
क्या चाहिए?
40 तो साफिल ले लो साफिल ले लो साफिल ले लो तो ये सब रख लीजिए एनोप्लास्टी के एंड में यूज़ कर लीजिए मिला साफिल मिला ओके नाउ इज द टाइम टू शो द फुल लेंथ ऑफ द कोलन that we have managed to construct.
So having finished the suture line there, we can see that from that misshapen mass of tissue which was the colonic pouch, we have got nearly 10 inches of colonic tube which has a good vascularity, bleeds from the end, and we hope will eventually be able to subserve colonic function. So that's the appendix, ileocecal junction, and continuing down the colon to the end.
ये दिखाऊंगी पेरिस्टल को पल्सेशन कहाँ तक मिलता है See, distal end sometimes creates problems, but even that is oozing.
And the vascularity of the tube is so good that the submucosal vessels will actually produce oozing from the distal end, despite there being no noticeable blood vessel continuing to that point. And it is important to check the lumen of the tube for uniformity before we pull it through to the perineum.
You will see it's bleeding right up to the tip. And you can see that it's
Pulsation.
arteries are pulsating. Right. Like that, and cut off these bits. और कुछ है कहीं मोटा?
स्फिंक्टर ही है।
चलो इसको देख लेंगे, इसको वहाँ रख देंगे। ओके, लीव इट। ठीक, नाउ चलिए अब बावल निकालिए बाहर, ब्लैडर बाहर निकालिए। एक एलिस प्लीज। Back up, please. Hold. Now, can you see inside? You can actually.
So it's now time to create the tunnel in front of the sacrum through which this tube is going to travel down to the perineum. And for this, the bladder is lifted out, and using a large artery forceps, the tunnel is created in the midline between the two ureters. You can see the right ureter clearly in the bottom part of the incision, and the left ureter is just to the side of the large forceps. This tunnel is created staying close to the urethra, and once the tip of the forceps appears in the perineum, it is used to draw in a needle to which is tied a length of suture. And this suture is then anchored to the end of the colonic tube, so that the colon, there you can see the tip of the forceps protruding out of the perineum at the site of the anus. And it is being used to catch the straight needle with the linen suture anchored to it.
Make sure that the orientation of the tube is correct.
Bowel to the linen suture, it is important to make sure that the colon does not get twisted as it is pulled down into the perineum. So it is important to pass the suture from side to side through the bowel rather than from mesenteric to anti-mesenteric border. Once anchored to the end of the linen suture, the colonic tube is placed in the pelvis in the tunnel we have just created. And following this, the rest of the bowel is deposited into the peritoneal cavity and the abdomen is closed, leaving an ileostomy proximal to the coloplasty tube.
चलो इससे ज़्यादा नहीं खोदेंगे. Okay, now let's do the ileostomy and close this. उठाओ, बॉल उठाओ, अंदर डालें, थोड़ा धुरैया लाओ. ठीक. this will lie right. अच्छा, we need to close all this here. इसको here रखे ना, mesentery gap. यूरिन जरा मॉनिटर कर लेना भैया. कट सर. अच्छा वेट, जस्ट गिव इट अ सेकेंड. हिला मत. You see pulsation right up to there.
Yes.
You can see the wall vessels pulsating, huh? Right along the tube there. Okay, good. क्या है? Right, sir. You put this in, you put this in, and we pull this out. ठीक. लाइए, एक वो दीजिए मोटी चिमटी. पकड़ लेना. लाओ. धुलाई और कर जाएगी. Hold and cut. अभी आउट ना करना भैया, अभी आधा ऑपरेशन बाकी है।
ठीक है सर।
आधा क्या मतलब 1/3। ना छोड़ दो, जस्ट कट इट, जस्ट कट इट। क्या हुआ?
हाँ छोड़ रहा हूँ।
क्या हुआ?
कल एक हर्निया का पेशेंट था सर, अचानक ड्राउजी हुआ, सबकॉन्शियस एबनॉर्मल मूवमेंट्स,
नहीं,
देयर वाज नो
नाम तो नहीं दिया गया था।
फेनोम दिया गया था।
तो सबकॉन्शियस एबनॉर्मल क्या हुआ? एक्स्ट्रा पिरामिडल हो रहा है
वही
भैया।
मतलब मसल डिस्टोनियाज जो होते हैं,
हाँ,
आई थॉट इट मतलब, लेकिन फिर उसमें इलेक्ट्रोलाइट हाइपोनेट्रीमिया 123
हाइपो।
बड़ा बच्चा था, फ्लूट पे था, 4 years 5 years था।
बट इनिशियली आई थॉट दिस
पेरिनॉम से नहीं, उसको कॉन्डेम दिया है।
नहीं फेनोम दिया।
पेरिनॉम से होता तो है वैसे एक्स्ट्रा पिरामिडल।
हाँ, क्योंकि उसकी डोज कंट्रोल बड़ी क्रिटिकल होती है भैया।
जी सर। ऑल ऑफ सडन so as such acute hyponatremia in surgical is very rare.
At least in elective.
And that too with when patient is exclusively on 5D, 10D or Vaseline or something.
ये इसमें वो एक एलिस लगा के पलट दो। हैं?
स्टोमक
सुबह बंद कर दिया, इसको वो कर दिया, मार्केट डी मार्केट कर दिया यहाँ पे।
छुट्टी पे थे मंडे।
हाँ,
सर नहीं है क्या?
आए थे कुछ लेक्चर वगैरह पीडियाट्रिक्स में।
आज है।
So that's the closure of the abdominal incision proceeding, with the ileum already anchored to the left lateral end of the incision at the site of the definitive ileostomy.
अभी पलटना है बच्चे को भैया।
में रखा है सिस्टर? अच्छा नहीं है।
विजय 202 फिर क्या माइक्यू दोगे?
जूम इन करो यार, फील्ड से बाहर निकल गए।
बताइए सर।
ऑल
Here we are just trimming off some excess skin which is overlapping the lower edge of the incision.
बच्चा लाइट है भैया, लाइट नहीं है, नहीं
दूसरे निडल होल्डर पे दे दो।
जीरो
जीरो
इसको पलटेंगे इसका। आइडियोस्मी जो है
जी सर।
along the long axis खोल के छोड़ दो।
ठीक
So, having closed the wound completely and anchored the ileum at the site of the colostomy, we now proceed to open the colostomy to provide the child with a channel for defecation in the postoperative period.
सिजर ला संजीत पोजीशन बनवा इसके रोल में लगा वो वाले चमड़े बंद कर दो मतलब पॉज कर दो
Once the colostomy has been opened, the child is turned over and put into position for the posterior sagittal rectoplasty, which will result in the formation of the definitive anal opening.
Knife, go. Knife, please.
And we can see here the linen suture which was earlier inserted inside out from the abdominal cavity, forming a guide at the site of the definitive anus. So we make the standard midline incision for the posterior sagittal anerectoplasty and carry it to the anterior margin of the putative anus. The tissues are divided strictly in the midline as standard, and one can see the good contractions of the parasagittal fibers and subsequently the levator ani muscle on either side of the midline. It has been our experience that the quality of perineal muscles in a child with congenital short colon is always better than a corresponding usual anorectal malformation with a rectovesical fistula. That apart, the incidence of sacral agenesis in children with congenital short colon is very low. We have seen only one sacral agenesis in more than 230 patients of congenital short colon. These two features, the presence of good quality muscle and the absence of sacral agenesis, are perhaps nature's way of compensating the child for not giving them a properly formed large intestine. And both the features come in very useful for definitive operation of coloplasty and posterior sagittal anerectoplasty. And here you can see the levator ani muscles on either side of the diathermy needle clearly progressing down to the side of the anus, better visualized than would be in the usual patient with high anorectal malformation as exists in this child. The division of the tissues is continued in the midline, and using the linen thread inserted previously as a guide, we get a pathway into the pelvis, and the end of the coloplasty tube appears in the wound by gentle traction on the linen suture. And there you can see it appearing in the wound, and all that remains to be done now is to orientate it correctly, perform the anoplasty and repair the levator ani, thus completing the operation.
Good oozing from the edges, red blood, so vascularity right up to the tip.
It can be clearly observed that there is still persistent bleeding from the end of the coloplasty tube, which attests to its good vascularity right up to the terminal part. And this is important because one of the complications of this operation is necrosis of the part of the coloplasty tube if care is not taken to maintain the vascularity adequately.
Retracted हिला करें, लाइन बैठ गया, बस तो वो हटा लो और ओके.
And just to demonstrate the common observation that the quality of muscle in patients with congenital short colon is better than a corresponding high anorectal malformation, we see electrostimulation of the levator ani, which is contracting symmetrically on either side of the wound. In fact, we can see the V shape of the levator ani muscle and the vertical muscle complex as they progress from the pelvis towards the site of the definitive anus marked by the artery forceps.
पतला, इससे पतला, 40. चलो 40.
Now, for proper orientation of the coloplasty tube to prevent it twisting and compromising the blood supply, It is important to remember that the suture line goes anteriorly. That is, the suture line of the coloplasty tube faces towards the front of the patient, and this marker suture is therefore placed firstly to prevent the tube from twisting as the anaplasty is carried out. Our midline incision had gone a little way beyond the anterior limit of the anus, and therefore that part of the incision is being closed off so that the end of the coloplasty tube sits precisely where the vertical muscle complex terminates near the skin.
Good.
And that is the first or the anterior-most suture, which also serves to anchor the tube in the correct position and prevent further rotation as the anaplasty progresses. The remaining part of the anaplasty is carried out with interrupted sutures, usually 8 or 9 in number, which approximate the skin edge to the cut mucosa. Placing a dilator in the lumen is helpful to prevent the needle from taking both walls of the coloplasty as it is driven through the tube. रहने दो यार, काटो उसको, क्या करेंगे ऐसा एटलीस्ट हो सकता है। नीचे वाले छोड़ दो, बस दो ये वाले रखिए। चलो उस दो तो
शायद रह गया
हैं?
था
नहीं ये वाला तो इधर है।
ये भी नहीं है।
नहीं वो तो अंदर वाला है, वो मिकोजा फोल्ड है। हाँ।
It is important to note here that there is free using of blood from the cut end of the coloplasty tube, and this reconfirms that it is actually vascularized up to the end. Sometimes when the vascularity gets compromised, the end of the tube will necrose and retract away from the anoplasty, leading to a closed perineum. In such cases, a contrast study through the ileostomy is helpful to delineate where the distal end of the tube lies, and it can then be approached by a revision posterior sagittal anorectoplasty. That is not an easy situation to handle, and luckily we have had to do it only once in more than 350 patients of congenital short colon, of which nearly 140 have undergone the coloplasty operation.
ठीक है ना, तो you can put a slightly bigger diameter also. है ना? चलो हो गया, काफ़ी मसल रिपेयर कर दी.
So that's the last stitch of the anoplasty, which is a U stitch which takes the bowel and both edges of the skin in order to provide a sort of watertight mucocutaneous anastomosis.
ठीक है. कौन है यार?
सही है.
क्या तो वो टीम है. कोई नहीं. चलो कट सर, दो एक स्टेज ऊपर लगा दें, निकालो उसको. फिर तो ठीक है. हो गया आगे उसमें, हो गया.
ऑल डन बस.
वो सब हो चुका है.
एक स्टिच करना है.
चलो सर, रोक दो भैया।
ड्रेसिंग लाइज
छोड़ दो एक मिनट।
That's the finished appearance of the perineum, and the child is just beginning to wake up out of the anesthetic. This completes the procedure of coloplasty. Thank you.